Dear participant, ladies and gentlemen, it is indeed a great pleasure for me to be here before you to speak on a very important subject, that is long-term repercussion of micronutrient deficiency. If you go through this slide, you see the global recommendations of appropriate feeding practices. Initiation of breastfeeding within 1 hour after birth. We all know that the breastfeeding is the best food for the newborn, and it is to be started within an hour, if possible before an hour. And it is really very important to start it within an hour. And if we can do that, 1 million deaths can be prevented. And if we go on adhering with it for at least 6 months exclusive breastfeeding, then we can save another 13% of death. And subsequently, if we can provide the appropriate micronutrients and energy rich dense complementary feeding, we can also prevent another 6% of death. So it is quite important to start with initiation of breastfeeding within an hour after birth and exclusive breastfeeding for 6 months, and thereafter, along with breastfeeding, uh, we have to add complementary feeding for better growth and development of our children. Rapid development after 6 months require additional nutritional support in the form of appropriate complementary foods. Now, if we go on to look into this slide, the optimal complementary feeding recommendations, infant and young child feeding complementary feeding guidelines. If we say infant and young child feeding, which means that it is the breastfeeding, exclusive breastfeeding for 6 months, and subsequently we have to add the complementary feedings along with the breast milk. Now, what we need to do according to guidelines, it is to be given timely, it is to be given in adequate in amount and variety, and properly fed and safe, hygienically prepared, stored and fed. Just have a look. 2 to 3 times a day for infants aging 6 to 8 months, and subsequently 3 to 4 times a day for infants 9 to 24 months. If you consider the time, and if you consider the adequacy, it is to be optimum in amount and obviously in variety. Now, properly fed. Fed according to child's appetite, satiety and age. We have always to be remembered that our infant is having a capacity of stomach only 200 ml. So we should not push or compel him or her enough food more than 200 ml. So we have to keep that in our mind always. And definitely satiety. As the baby do not like to take it, don't give it. Don't push. Under compulsion feeding is not necessary, and obviously it does not help. Regarding safety, there should not be any compromise. It should be the complementary feeding should be hygienically prepared, stored and fed. And we have to ensure it to avoid the infection, as because infection leads to malabsorptions and so on. Now, let us have a look. What is the current situation of complementary feeding practices in Bangladesh? Regarding the timely, 38% of the infants are not introduced to complementary feeding at the appropriate time of 6 months. That means they are starting it either earlier or delayed. Regarding adequacy, 72% of the infants are not fed with appropriate number of food groups, and 37% do not receive minimum number of meals. So, and regarding the properly fed, 77% of the infants between 6 to 23 months are not properly fed. Regarding the safety, unhygienic complementary practices may be one of the contributing factors to infections among infants. So overall the scenario is such that 77% or nearly 8 in 10 young children fail to be fed according to the recommended infant young child feeding guidelines. So which is really alarming. Now have a look. Suboptimal quantity of nutrition among young children in Bangladesh. Inadequate quantity of complementary feeding among 6 month to 23 months olds. 72% are having inappropriate number of food groups and 37% minimum number of times. And if we think of about the vitamins and macronutrients, we can have a look that the zincs are being taken from our food 72%, vitamin C 80%, and vitamin B12 28%, and vitamin B2 22%, and iron 22%. So there is a big gap that we are not having the adequate number of vitamins and minerals from our food. Young children in Bangladesh meet less than 50% of the adequacy levels of key macronutrients. Now, if we go through this slide, the percentage of infants who do not consume nutrition-rich food, that is 6 months to 23 months old, they are deficient in 60% of milk and milk products, eggs nearly 60%, fruits around 70%, lentils 60%, fish is abundant in our country. Even then there is a deficiency of 40%, and chicken 80%, and green leafy vegetables 40%, which means that 1 in 5 children do not meet daily dietary diversity score. Now, undernutrition in Bangladesh. We all know that we are having some problem with the nutrition, and 45% of our children below 5 years of age are malnourished. So nearly 4 in 100 Bangladeshi infants die before completing 1 year of life, which is really alarming, and we cannot go it. We cannot allow to go it. 3 in 100 Bangladeshi children die before completing 5 years of life. So malnutrition is among the leading cause of death among young children in Bangladesh. Now, ladies and gentlemen, if you go through this slide, have a look. We always concerned about the mortality, but we do not think or do not give emphasis on morbidity. But in fact, the infant mortality is just the tip of the iceberg. And the other things which are not seen but really alarming are underweight, stunting, lost productivity, hidden hunger, impaired mental abilities, and recurrent illness. So we have to look all these carefully and giving emphasis. Dear participants, now I will discuss on a very important topic, that is the hidden hunger, which is really a global problem and a burning issue globally. Now, what is hidden hunger? Hidden hunger is a form of undernutrition that occurs when intake and absorptions of vitamins and minerals are too low to sustain good health and development. So according to Dr. Gautam, former Deputy Executive Director of UNICEF, the hidden hunger due to micronutrient deficiency does not produce hunger as we know it. We might not feel it in the belly, but it strikes at the core of your health and vitality. So if we go through a statistics, globally, iron deficiency is almost 1.6 billion, and vitamin A 190 millions under 5, and 19 millions pregnant women are having vitamin A deficiency, and the zinc 1.2 billion, and iodine 1.8 billion. So there is enormous gap between the intake and the amount that we should have in our food. Now have a look, the cost of the hidden hunger. More than 2 billion people worldwide suffer from hidden hunger, and almost twice the number of those suffering from hunger of food. Really, it is huge amount. If you consider about the other aspect, approximately 7% of the annual global disease burden is there, and 2 to 3% loss of GDP, and almost 9% of global childhood disability adjusted life years, and more than 10% losses of lifetime individual earnings. Really we need to think of all these things. and we have to do something to combat all this situation. Now definitely there are some burdens. We have to consider the burdens. Prevalence of micronutrient deficiency in Bangladesh among young children. Now let us have a look. If we go through this slide, we can see that the anemia which is prevailing in our children 51% from 6 months to 23 months old, which is really very high, and vitamin A deficiency 20%, and iodine deficiency 40%. We all know that iodine is very important micronutrient which helps us to increase our intellectuality and cognitive functions. So without iron we cannot go. We have to think of all these things. Zinc, which is also 50% we are deficient, and if we do have zinc deficiency in our early lives, especially less than 2 years of life, stunting is a problem. And that's why we have to consider all these vitamins and macronutrients in a different way, giving emphasis on them, and we have to try to minimize all these deficiencies. And we have seen that non-adherence to the appropriate complementary feeding practices contributing to the burden of micronutrient deficiencies among young children in Bangladesh. So we have to advise the parents, we have to advise the mothers or the caregivers that we continue along with the breast milk, you have to continue the complementary feedings, and up to 2 years you can go on with it. Now, the hidden hunger during early years a grave concern. In severe form, we see it is the protein and malnutrition, and again, if it does occur, there is stunting. And on the other hand, if there is mild to moderate micronutrient deficiency, that is subclinical form, the hidden hunger is there. So hidden hunger, if not corrected, can lead to a grave consequences such as stunting in the long term. As you all know that if there happens in stunting, it will remain forever. Stunting Bangladesh picture. It is really alarming to us. Now have a look. According to the Bangladesh Demographic Health Survey 2014, 36% of the children below 5 years of age are reported to be stunted. We cannot allow it. We have to do something. We have to take into care of it. You see, from 6 months to 23 months, the stunting is much more than the other ages. So there is a window period where we can take some measures and minimize the stunting. And highest rate of stunting are seen during the complementary feeding periods. If we go through this slide minutely, physical growth, a stunted child may remain short for life, and cognitive functions, which is quite important. Nowadays, all people are having 1 or 2 children. So we need to develop them in such a way that they are the best. So if we really want to do that, we have to provide the adequate nutrition as well as vitamins and macronutrients before 2 years. If we can provide them, then they will be up to the mark. If we cannot, then the cognitive functions will be deteriorated. And according to statistics, 16% increased risk of failing at least one grade in school, and lower IQ by as much as 15 points, and threefold increased risk of dropping out of school. Really, we cannot allow it. We have to think of it. We have to do something to rectify it. And impaired immune health, we know that if we cannot provide healthy food in appropriate time, the immune systems will not develop as per age, and there will be always risk of infections. So risk of repeated illness is there, and at the same time fourfold increased risk of death as well. So we have to do something to minimize this situation, to come out from this real scenario. So undernutrition can impair a child's lifetime learning ability and productivity. Dear participants, have a look. The infection and malnutrition is a vicious cycle. Inadequate nutrition, altered metabolism, illness and infections, and nutrient loss, reduced intestinal absorptions and intake, and subsequently there is again nutritional deficiency, and again the cycle goes on. So if you allow it to go it on and on, then there will be definitely some deficiency, and it will be too late if we do not intervene within 2 years. Now, micronutrient deficiency and the clinical practice. We have to give the priority when it is obvious. I mean to say that clinically manifested nutritional deficiency needs priority. On the other hand, insidious subclinical macronutrient deficiency, we can come out from these conditions if we can intervene with education and awareness. So, if we can go for education and awareness, obviously there will be some attitudinal change and the situation will be different. So, we don't need to prioritize this, but we have to think of it and we give emphasis on it. We do something for it when it is in subclinical form. If we can do it, only then we can come out from this devastating situation. So, subclinical deficiencies require much more attention through a definitive educational structure and for both the pediatricians and the general public. And if we can aware the mother and the caregiver or the parents, whoever may be, then if they can do according to the advice, education, they will be definitely doing much more better than earlier. Now, how can we assess hidden hunger? Micronutrient status in hidden hunger are difficult to assess, obviously. As it is in subclinical form, we often miss it. But what we need to do, that we have to take meticulous history of the maternal, medical and nutritional history, and on the other hand we have to take meticulous history regarding the dietary history and the infant medical history and infant anthropometry and the complete blood count if needed. So the window of opportunity to prevent hidden hunger is the first 1000 days, that is from the conception to 2 years. So whatever we need to do after basic assessment, we have to go for it immediately, intervene it. If we can do that, definitely we'll be able to minimize the situation from getting worse and worse. So clinical evidences during assessment such as faltered anthropometry states are on indication that it is too late to prevent hidden hunger. The window of opportunity is within 1000 days. Whatever we like to do, we have to go for it within 2 years of age. So if we can do that, definitely the outcome will be different and will be helpful to us to minimize the situation. Now, complementary feeding period, a critical window of opportunity that I was just telling in my previous slide. What we need to do, we have to do within this window period, that is from 6 months to 24 months. And if we go on for correcting it after 24 months, it will be late and we may not correct it. We cannot get the optimum result from our all effort. Now, challenges in conducting comprehensive nutritional assessment. Well, as I mentioned earlier, really it is difficult to assess, difficult to sampling, and time consuming. Some procedures may be invasive and difficult to apply at a field level. Even that, in spite of all these limitations, we have to go forward. We have to do something to reduce these micronutrient deficiencies. We have to provide adequate information, knowledge to the caregivers so that they can give importance from 6 months to 24 months, as because this is the time where the interventions will help us. Definitely from this presentation, you might have some queries in your mind. So let us have one of them. Which macronutrient is the primary burden during complementary feeding period? Obviously, all of you will agree with me that it is the iron. As soon after the baby is 6 months old, he or she needs extra food, extra energy, extra vitamins and minerals. So if we cannot provide all these things during 6 months onwards, there will be a huge gap. If you go through this slide, you see there is an energy gap, there is also protein gap, but the huge iron gap is there. So what we need to do, we have to intervene. An intervention with energy rich, safe complementary feeding. And if we can adhere to that, we will be able to change this gap or minimize this gap. Otherwise, there will be obvious manifestations of the deficiencies. So suboptimal nutrition can cause an irreversible damage to the infant's growth and development, which we cannot allow. We have to do something, and we have ample of scope to do it. And definitely, if we are aware of it, we can do it. Okay, ladies and gentlemen, if you have a look into this slide, 5 out of 10 young children in Bangladesh are anemic. And the prevalence of anemia is more in 9 to 11 months, and thereafter 12 to 17 months, and thereafter 18 to 23 months. So these are the time where the anemia is prevailing in our country in under 5 children. So anemia is prevalent not only in the people or in the families where there is some economic problem, but irrespective of residence and socio-economic status, we are having this problem. And that's why around 50% of our children are anemic. Maybe it is because of our lack of awareness, because of our nutritional problem, or because of our some medical illness, or because of our food that are not containing adequate amount of iron, or the bioavailability problem. So the cost of iron deficiency anemia, if we go through this slide, we can well understand if there is iron deficiency, there is iron deficiency anemia, which may be moderate or severe. And if it does occur, there is impaired cognitive development, low physical activity, and all causes mortality with severe iron deficiency anemia. And impaired cognitive development, that is low adult weight and productivity loss is there. And if there is low physical activity, definitely the daily adjusted life years are being lost. So iron deficiency alone results in an overall loss of 3% DALYs. So it is really a thing we need to keep in account, and we do something for it, and we have to do it within 2 years of age. Now, if we think of the other queries, or you might ask me, is home-based diet enough to bridge the gaps in nutrition among infants? I will say certainly not. Most pediatricians agree that the current quality and the quantity of home-based complementary foods are unable to meet the daily requirements or the regular daily allowances for the most micronutrients. If you can give a meal, midday meal, and the evening meal, and plus the snacks, still there is iron gap. So the largest gap remains for iron. Now we have to think why it does occur. Where is the problem? What we need to do? Now, what are the factors contributing to this iron deficiency during the complementary feedings? First of all, the large dependency on the cow's milk, which is a poor source of iron. Compromised quality and the quantity of complementary food. Limited caregiver knowledge. Inadequate healthcare services and unhealthy environments. All these are the contributing factors for the iron deficiency anemia in a period from 6 months to 23 months. Ladies and gentlemen, so far we know that we have problems and we have limitations. Limitations of resources, limitations of funds, and limitations of expertise. Even then, in spite of all these limitations, we cannot sit idle. We have to go forward, and we have to do something to decrease these deficiencies. Many organizations are working unitedly to come out from all these problems. If we mention here that the Bangladesh Breastfeeding Foundations, Ministry of Social Welfare, Bangladesh Pediatric Association, Community-Based Kangaroo Mother Care, Director General of Family Planning, Director General of Health Services, Institute of Public Health Nutrition, National Nutrition Program, and Bangladesh National Nutrition Council, and various ministries are incorporated in all these organizational network. But in spite of all these effort, we are still lagging behind. We have to go forward. We have to work unitedly and all together. And if we can do that, definitely this scenario will be different in coming years. In spite of all these efforts, up till now, still we are having weak in implementing our different protocols, like the early initiation of breastfeeding, exclusive breastfeeding up to 6 months, introductions of complementary feeding at the age of 6 months, and the infant and young child practices guidelines. And still we are not in a position to provide all our children the iron-rich food. Despite the vast interventions, less than 50% of young children are not fed as per infant and young child feeding guidelines. So we have to think of many things. We have to do something unitedly, and taking the community participation is a key factor. We need to go to the community. We have to educate them. We have to make them aware, and we have to make an environment which will help us to come out from all these deficiencies. Now, if I go on addressing the barriers, why we are still lacking behind in spite of united effort, we can see that poor dietary habit is a factor. Inadequate government funds definitely is a factor. And public-private partnership is not going well as per just our program. Inadequate awareness and lack of education. I want to say something here that we need to prevent this situation. We all know that prevention is better than cure. I would like to add some adjectives to this in a way that prevention is not only better than cure, it is cheaper than cure, it is wiser than cure. So we have to go for it. And if we want to go for it, we have to educate our mothers and caregivers. We have to make them aware of it. We have to bring some attitudinal changes. And if we can do that, definitely we'll be successful. And on the other hand, still we are having lack of leadership. And I will request all my colleagues to come forward to take the leadership. And someone should take the initiative to go on along with. And if we can do that, if we can provide a good leadership, definitely the situation will go ahead and will be much more rewarding situation will be there, and we will have less problem in our children. Now, individual assessment and management of micronutrient deficiencies. What we need to do? Our complementary food should be as such that it is to be given in the right time, in right amount, in the right way. And the complementary food should have culturally acceptable dietary diversity. Out of 7, at least 4 should be there. Optimal caregiver education doesn't have any alternative. We have to go for it. We have to go to the root level, grassroots level, and to educate the mothers, caregivers. We have to take into consideration the community as a participant. And if we can do that, I think the success will be much more easier. Limiting the sugar and the salt content in the complementary feeding is always advised by the WHO and by our different organization as well, and in our practice and guideline practice is also there, as because it doesn't help, rather it deteriorates the situation in the long run. Condemn the use of cow's milk as a sole source of nutrition during complementary foods. And standardizing clinical assessment protocols, that is quite important. We are lacking behind. What we need to do, that we have to provide, or we have to develop a protocol that will help us to diagnose all these subclinical form earlier. Still we are lacking on these protocols. Developing new non-invasive methods that can function on a principle similar to pulse oximetry. With the pulse oximetry, we can assess within a minute the oxygen saturations, carbon dioxides, and as well as the pH. So if we can develop such a non-invasive minute devices that can help us to assess the subclinical form of micronutrient deficiency, we have to think of it. It's not possible, it's not impossible, it is possible. And if we go on to do, and if we go on to think of all these things, definitely some days some devices will come out that will help us to identify the subclinical form of micronutrient deficiency earlier. And if we can do that, we'll be able to intervene it earlier. And we have to always think that the hidden hunger and the start intervention to achieve regular dietary allowances and assess retrospectively. Ladies and gentlemen, I'm just about to finish my presentation. Just prior to that, I would like to sum up these scenarios and my presentation as well. We have limitations, and definitely we have some obstacles, and at the same times we have resource limitation as well. So what we need to do, in spite of all these limitations, we have to go forward. The initial 6 months is the prime time for a newborn. And I will request to all my colleagues to convey the message that the breast milk is the best, and there is no doubt of it. We have to put our children, newborns, soon after birth into breast within an hour. And if we can put that, at least 1 million deaths can be prevented. And subsequently, if we go on with it for 6 months, 13% more death can be prevented. And along with breast milk, if we can provide the appropriate complementary feeding, another 6% death can be prevented. So that is very important, and we have to do it. We have to nurture the nature. As you all know that the breast milk is the ideal food for the newborn, and it has a tremendous capability to change its composition, to change its concentration, and to change its flow according to the need. Initially the breast milk, which we call the colostrum, is very important, which is thick yellowish color and having antibodies, neutrophils, macrophages, and also the nutrients necessary for the first few days. And subsequently the composition changes, and we call it transitional breast milk, and subsequently the mature breast milk comes. So if we can provide exclusive breastfeeding initial 6 months and thereafter, as the child grows, demand increases, we have to put the child along with the breast milk some other foods that we call the complementary foods. So the complementary foods to be added at the age of 6 months along with breast milk. We are not asking to stop the breast milk. Along with breast milk, we have to provide our children from 6 months onwards the complementary feedings, which is energy rich, dense, and having a diversity of food and definitely adequate in amount, and it must be safe enough so that there should not be any infections or other things. So what we need to do, initial 6-month exclusive breastfeeding and subsequently along with breastfeeding complementary feedings to be added to minimize the energy gap, to minimize the iron gap, to minimize the vitamin A deficiency or gap and the other micronutrients. So our complementary feed should have all the diversified ingredients so that it does not become a monotonous to our children. So we need to provide them a good complementary feeding, and at the same time we will continue the breastfeeding. So if we can do that, or if we really want to do that, we have to make our parents, we have to make the caregivers much more aware of all these situations. If we really can do that, definitely in coming days the problems with the stunting, the problems with the growth and development will be less. And if we really wish to do it, definitely we need our hands together. We have to put our all hands together. We have to fight along with all to achieve the goal. One cannot do it. Two cannot do it. One organization is not sufficient. Two organizations is not sufficient. But all the organizations and all the peoples, all the expertise, if wishes to do it, it is possible. And I think we all want to do it, and definitely will do it. We have to do it for the next generation betterment. Thank you very much. Thank you for your passion sharing. Thank you.